Let's analyze the main sources of errors for the evaluation of wall motion abnormalities. The first usual problem is to identify the endocardial borders of the walls in an apical view. If you look here, you may think that this is all the lateral wall. The impression that we have is that it is moving apically at each systole, but it's not thickening properly. Since we should analyze thickening rather than movement, we would say that this wall is hypokinetic. But this is a major problem, since in the apical views we may not see where is the endocardium. One of the possibilities to solve this problem is to use microbubbles contrast. Look what happens when we use microbubbles. That structure that we were seeing here is in reality the pericardium. The endocardium is in front of it. See here the endocardium, and the wall has the same thickness as the IV septum and is contracting perfectly alright, as you can see. So the use of contrast is very important, mainly when doing a stress echo and you are not visualizing properly these walls. Frequently, you may not be certain what happens, mainly in the lateral wall. You may increase the gain, do whatever you may, and it's not possible to define the wall, what makes indispensable the use of contrast in some patients. Look here. We are using an echo without second harmonic, only with the fundamental frequency. It looks there are dyskinesia of the apex and a poor LV function. But see what happens when you use second harmonic. We see that the apex is not dyskinetic. What is happening is that the whole heart is moving apically. It's only an intense ictus cordis in a hypertrophied heart. See how the apex is pushing the thorax wall. It's not dyskinetic, since you see that this part of the apical lateral wall and this of the apical IV septum contracting normally inward. The whole heart pushes the paracardiac structures as it moves apically. We can see also that there is hypertrophy and good left ventricular systolic function, which were not identified before, but the lateral wall is still not perfectly shown. When we use contrast, we can now see perfectly the endocardium and then notice the normal thickening of the walls. We always have to be careful while analyzing wall contraction. This is an apical two chambers. The mid-third of the inferior wall seems to be contracting. The apical third looks akinetic. The basal third looks fibrotic, but then you may have the impression to see some thickening here. Be careful. Exist conditions that may simulate contraction. In this case, there is a bright wall that seems to be contracting in LV mid-third, and when it thickens, it produces a line of reverberations down at the basal portion, giving the wrong impression that the wall is thickening, but it is not. The reverberation line can be seen even behind the left atrium. Be careful also with oblique X. Look here at this short X at the mitral valve. You may have the impression that this region here is dyskinetic. Everything is contracting well except for this region that is expanding during systole. This is not dyskinetic. In a perfect short X, there is no dyskinesia, but an oblique view, this here is the mitral ring. We're entering already the left atrium. This region here of the inferior IV septum may also deceive you. Many normal walls may seem to be hypokinetic in this region. This case, for instance, is a normal young man. Every wall is thickening well, except right in here, in this very small region, at the junction of the AV septum, inferior wall, and inferior right ventricular wall. One of the main pitfalls may be when analyzing the most basal area of the posterior lateral, or the inferior wall, when you see the mitral valve in a perfect short axis view. Due to systolic apical translation of the heart, what you see in diastole is not what you see in systole, at the same being position. In this view, you are seeing the basal ventricular walls during diastole, and the mitral ring or even left atrial wall during systole. Since both move backward during systole, you may mistake it as a dyskinetic wall. In this case here, it's easy to know the difference since I select this image to show you clearly the origin of a possible mistake. But in some cases, mainly with bad image, it may be very difficult to be sure. Look this example here. All the walls are contracting except for this inferior wall that seems to be akinetic, denser and thin. It looks like it's fibrotic. Now let's incline the beam just a little apically, and we see it's contracting well. But this may happen if the basal portion has a problem, but not the mid-third in the papillary area. Then, if we incline upward in the direction of the left atrium, we can be sure we see the mitral ring, and that this wall here sometimes is left ventricular wall and other times is mitral ring and left atrium. How to solve this problem? Is this a real wall motion abnormality or just due to translation of the heart? Well, it's very simple. Forget these short X views and watch the apical view. Mainly the two chambers and the long X. Look here in this long X that the posterior wall is contracting normally. There is no dyskinesia. Another problem of a false dyskinesia of the inferior wall. It's different from that seen before with the mitral ring. You can see here that during systole, this inferior wall expands outwardly as being dyskinetic. What is happening? When we see the long X, this dyskinesia does not exist. Neither it seems at the apical long X. This is a relatively frequent problem, usually in obese patients. What happens here is relatively simple. See how this wall moves extensively toward the apex. With the whole heart moving apically, our short X may have the beam passing here during diastole, and as the heart moves toward the apex, we are then showing this wall here, more toward the base, and the impression that we will have is that this wall has expanded outward and it's dyskinetic. Look here. Everyone may think this is dyskinetic wall and that the patient has coronary disease. But watch now the long X. The wall contracts normally. Apical long X, why does it contract so well? You know already. This is not dyskinesia. During diastole, we're seeing this area, and during systole, this other area, more distal, and have the impression of an expanding wall that does not exist. It's a very frequent pitfall. It's always the same. We're doing a long X view and we do not notice any problem of wall contraction. There is left ventricular hypertrophy, but no dyskinesia. Then, when we're seeing the short X, we're surprised by the dyskinesia of this wall. In this situation, when we are at the apical long X, or two chambers, we do not see any dyskinesia. See how the wall contracts perfectly well. So there is not this expansion when seen in longitudinal parasternal or apical view. Once again, what happens is that during diastole, we're here, and during systole, the heart moves apically, and we're not here in a short X, and hence more distance from the transducer, and with aspect suggestive of dyskinesia. It is interesting that in these patients, if we perform 2D speckle tracking, it will be normal in these walls, showing that it's really not a dyskinesia. But the study of speckle tracking will be in others lectures.